We are now live, hopefully, and people can see the screen. Yay! So I can give you a little bit of lecture tonight and answer questions that you have about abnormal psychology. Those of you who have been on the line for a long time, thank you for hanging in there. I greatly appreciate it. There's a good number of you here, so that's good. I'll reprise the announcements real quick. If there's any questions, just type them into the chat box and I'll hit it. MindTap problems, use the link in the MindTap area of Blackboard to go to student resources and then contact Kevin DeLeon directly. He'll help you. There's a link on Blackboard now that says webinar replay, and this is where you can take a look at the video from last time. I'm also going to put up audio from last time. I'll also put up the audio and video of this time, and I will put the slides that I'm using in that area so you have all of it handy. And I think that was it, if I remember correctly. Junk email stuff was getting stuck in my junk email. I sent the email about that out earlier. Call me at the number on your syllabus if you need anything. All right, let's get into the material because it's already 8:36. Holy smokes. And I don't want to keep you here all night because there's probably something good on television tonight, right? I don't have any idea what's on TV. But let's talk about abnormal psychology. And I don't want to lecture you to death, and I'm certainly capable of doing that. What I'd really like is any questions or observations that you've had from your readings. If you could just type them in to the chat box. What do you like? What do you not like? What are you interested in? What do you want to know more about? And I'm happy to address any questions that you have. Otherwise, I'm going to hit what I would consider to be sort of the high points, the take-home messages that you should be getting from chapters 1, 2, and 3 to really understand the foundational pieces of abnormal psychology. So I'm just going to start. You can chime in anytime with a question, interrupt me live on the phone, chime in with a question in the chat area. I'll keep an eye on the chat box. I can see everything being typed in. And if you just want to offer generic comments about anything, just go for it. Pretend like this is class, but you don't really have to raise your hand. All right? So again, though, I'm not going to make this a comprehensive sort of thing. In all of these slides, you'll see I've got like 90 different slides here. I'm just going to give them all to you. It's nothing that really isn't in your textbook. It's just things that I think that are good to know. So this idea of what is a psychological disorder is a big question in abnormal psychology. It's important to remember that we don't have a single definition, but there's different ways that we look at psychological disorder to actually define it. So we don't have a good way of knowing what's normal or what's abnormal. It's all relative, and it's relative to the people that we're comparing you, or whoever we're interested in, that we're comparing you to. And it's influenced by things like culture, age, gender, you name it. And it also is dependent to a certain degree on who's doing the evaluating in order to make the judgment. And that's a term that we use in clinical science all the time, clinical judgment. So anytime you go to see your doctor, you'll get an evaluation done. And it's probably not much of one if it's your primary care doctor. It's probably even less of one if they know you well. But the doctor is evaluating you for the purpose of coming up with hypotheses. And the hypotheses of what is wrong with you at that moment is basically, what do I think is going on that makes Betsy different today than she normally is? And what makes Betsy different than a woman of the same age with a generally similar health status? What's different? And so the idea of disorder shouldn't be confused with just being different. When we talk about a psychological disorder, we're talking about abnormality taken to a whole new level. And the new level is one that includes things in addition to just being different. So remember, the concept of being abnormal is just simply a matter of being different than your peers, on an outlier on the normal curve. And so I'll try not to flip around too much. But if I can bring up something that I think is useful to you, I will. So, for example, if we just look at the concept of a normal curve, this is a more statistical sort of model of the normal curve. But if you think about the statistical concept and forget about all the notations of standard deviation, but what this essentially is a plot of almost any human characteristic. And it tends to follow this bell-shaped or normal curve, where that little indicator up at the top of X with the line over it, that would be the mean or the average. And this notation here means a standard deviation. And we look at things in terms of a standard distance from the average. And the big swath in the middle will capture roughly 68% of the population. So if we take, for example, IQ, which is a little bit easier to look at and conceptualize, or quantify better than, say, anxiety per se, we'll know that the average IQ is 100, the standard deviation is 15, and so anything from a range of 85 to 115 we would consider to be normal or average intelligence, and that would be 68% of the population. And then we have a certain portion of the population who is abnormal, meaning outside of the norm. These would be, on this end of the spectrum, 2 standard deviations above the mean. So this would be an IQ of roughly, we would consider this area here where it says 14%, we would consider that to be 1 standard deviation above the mean, because it's the space between 1 and 2. And so in this area of 1 standard deviation above the mean, it's another 15 points. So we're looking at roughly an IQ of 115 to 130. That would be an abnormally high IQ. Okay, it's different, but it's not dysfunctional. And when we talk about psychological disorder, we talk about dysfunction. So if we go to the left side, doesn't look like you can see my mouse, but if you go to the left side of the image and we see 1 standard deviation below the mean, this captures 14% of the population. So roughly 14% of the population will have an IQ that is somewhere between 85 and 70. Okay? So 70 to 85, then 85 to 100. Okay, so these are people who are abnormal. They're not necessarily dysfunctional, but they have an IQ that's lower than that of the typical person, and don't necessarily confuse the number of IQ points with some sort of functional ability. IQ varies. You learned about that in Principles of Psychology. But in the case of mental retardation, we would call a person who is 2 standard deviations below the mean, meaning 2% of the population. These are the individuals who have an IQ of 70 or below. Very abnormal. But in order to get labeled with a psychological disorder, namely mental retardation, you can see from our judgment, from our indication here, you would need some sort of psychological dysfunction and impairment. So in the case of mental retardation, just because you have an IQ that is 2 standard deviations below the mean, i.e. 70 or less, doesn't necessarily mean that we would give you the psychiatric label of mentally retarded. We would only do that if your IQ was less than 70 and there was some sort of functional impairment. So if you come out with an IQ test score of 68 on the Wechsler, intelligence scale, that isn't great. It's better to have a higher IQ than a lower one, obviously. No secret there. But is it mental retardation? Well, the answer is no. No, it's not, unless there's a functional deficit. So it's just something to keep in mind when you think about psychological disorders and abnormal psychology, that we have this idea of disorder, And that's different than just being outside of the norm. I hope that makes sense. So is there any questions about that? Do you think that's the reason people are falsely diagnosed so often? Falsely diagnosed as mentally retarded, Julie? Or generally speaking? Well, maybe you mean generally speaking. And Betsy's question seems to suggest that. Can personal bias in the practitioner have a bearing on the diagnosis? Absolutely. Absolutely. Julie says no from the beginning. Okay, yeah, interpretation. Right. So, certain disorders are more likely to be misdiagnosed more frequently than others. And there's lots of different reasons for that. Some diagnoses are harder to make. So for example, when they changed the diagnostic criteria for autism, they got rid of a diagnosis called Asperger's syndrome. And now we have this disorder called autism spectrum disorder, which doesn't really lead to a lot of diagnostic specificity when labeling a disorder. It's very vague and it's very open, and it's easier to make the diagnosis and be right because it's a wider area to hit rather than one little specific disorder. So in some ways it would make it easier to misdiagnose somebody as having a form of autism. That's probably okay because historically there's been a lot of cases of autism that into adolescence were never caught, and then they get to be adolescents and young adults, and we're sitting around scratching our heads saying, how did we ever miss this? And I knew it was just a matter of time before we come up with ADHD. ADHD being diagnosed too frequently, and Anna suggested because the physician pays close attention to the parent's concern rather than observation, and this is exactly right. This is exactly right. And so, again, I'm just going to keep bringing up Google. And so, for example, if we just look at the ADHD criteria, whoops, I'm showing you something that doesn't make any sense. So if we look at ADHD symptoms and diagnosis of criteria from the Centers for Disease Control, so you can see here the diagnostic criteria, the new diagnostic criteria for the DSM-5, where you have to have 6 or more symptoms of inattention for children up to age 16, 5 or more for adolescents and up, 17 and up. So fails to give close attention to schoolwork, trouble organizing skills. These are things that a parent could say, oh yeah, they got that, they got this other thing, sure, yep, mm-hmm. And then hyperactivity, yep, mm-hmm, yep, got all these things, fidgets. Some of this will be clearly biased by how much it bothers the parents. Okay, and I'm not blaming parents, it's just sort of the way that it is. But here's the clicker, here's the really important thing. If you can see my little highlight there. Several symptoms, in addition to the conditions of hyperactivity or inattention being met. So let's say you meet those. You've got other criteria that have to be met. One of which is that several symptoms are present in 2 or more settings. So think about what that says. Several symptoms are present in 2 or more settings. So it's a little bit sketchy if a diagnosis is made just based on parent report. It has to be based on the report of people who have observed the kid in 2 or more settings. Now you could say, well, the parents are accurately reporting what the teacher is saying. Maybe so, but the better way to do it would be to actually talk to the people or have questionnaires completed by people in those multiple settings. Also, there has to be clear evidence, some of this is legalistic, but clear evidence that the symptoms interfere with or reduce the quality of school, social, work functioning. So if you just kind of get the idea that the kid is odd, but it doesn't really interfere with functioning, we're not really likely to label that as ADHD. And with almost every disorder category, this is stuff really is kind of out of chapter 3, to be honest. There's always this exclusionary criteria. And the most common is it's not better explained by another mental disorder. So if you look at the conditions of inattention, we know that if people are anxious or if people are depressed, their attention and concentration are poor. Okay? So you can imagine the case where a teenager is depressed and they're failing to give close attention to details and making careless mistakes in schoolwork. Well, they're depressed. They're not going to be all that focused on the details. Trouble holding attention on tasks or play activities? Well, if you're hanging around with a bunch of kids and you have social anxiety, you're probably not going to pay attention very well. So it's really up to the diagnosing clinician to make the judgment as to whether or not the kid meets the criteria, and if the kid meets the criteria, whether or not that's the best explanation. And we always tell clinicians that when you're evaluating people, you should be forming hypotheses and then trying to disprove your hypothesis. So this is hard because we all specialize in things. And so if I'm a specialist in ADHD, then parents are going to bring me their kids. And the kids are probably only going to be referred to me because people suspect ADHD. And if I'm really good at diagnosing ADHD, I'm probably going to see it in a lot of places where maybe it isn't. So the responsible thing to do is to try to argue against a diagnosis of ADHD so that I'm not overdiagnosing. That's a tall order. And most of you don't have the experience of going to your primary care doctor and having the primary care doctor work really hard to disconfirm a hypothesis. So you're hitting on some important things, and I'm hoping that that sort of makes sense with respect to diagnosis or misdiagnosis. So Anna's daughter, ADHD, numerous assistant teachers, depends on the doctor. Good, you guys see. Okay, so this is exactly what I want you to do when we're on these calls, right? Chat back and forth. Try not to fight with each other, but whatever. Not wanting to diagnose. Yep, these are all things. Doctors are a little more cautious now about administering medications, and they're a little bit more cautious about labeling something as ADHD when it could be something else. That happens quite a bit. And in fact, one of the things that we're trying to get doctors to do, pediatricians to do, is not diagnose ADHD until the child has had a sleep study. So one of the things that I just see here now is ADHD is being incredibly hard to diagnose in a 7-year-old. And this is true. This is true. However, if you're well trained and the clinician knows what the diagnostic criteria is and has the skill to assess properly, it really isn't that hard to make the diagnosis. The problem is, and don't hear this the wrong way, and don't go running to your pediatrician and tell your pediatrician that, Dr. Hanley said you don't know what you're talking about. But pediatricians really aren't trained to do detailed psychological evaluations. They're really trained to assess symptoms. They're not trained necessarily to observe behavior. Now, of course, they observe behavior, and the more kids that you see, you're going to get better at it. But all of you are raising really good points. These are the challenges in assigning a diagnosis and labeling something as a disorder. This is why I think the treatment of kids is one of the most difficult things ever, because you really have to understand what's developmentally appropriate, what's developmentally normal for a kid versus what is just the symptoms. So the symptom criteria we were talking about earlier, they're important, and you have to understand what inattention looks like, and you have to understand what impulsivity looks like. But in order to rate it as abnormal, you have to know what looks typical for a child of that age. And a 7-year-old in a classroom looks very different than a 15-year-old in a classroom. It's a whole world of difference, right? And this is why the elementary school classroom looks very different than the college classroom. It has to, because these kids can do different things. And so it's important when you're thinking about labeling people and assigning what is abnormal and not, that you understand what normal is. And I've always told people, if they, you wanted to go into a field where you wanted to be a child therapist, you should probably spend a lot of time with normal kids so you understand that. Otherwise, you're going to probably overdiagnose people as having psychopathology. So, all right. So I gotta correct something, Jillian. You actually don't get addicted to Adderall. It's not something upon which you can develop a psychological dependency. It is a very popular drug of abuse. And again, you have to make a judgment call when you're choosing a treatment. And this is why the whole process of what's abnormal, what's a disorder, what's the diagnosis, why getting it right is so important. Because and again, you can have all kinds of different opinions about what's best, and I'm certainly not going to suggest what's best for any one individual, because I didn't evaluate the individual. The research would say very clearly that medicine as a treatment, particularly things like Adderall, which is speed, a class 2 controlled substance, is very effective for ADHD. And kids who are treated with medicine for ADHD do better than kids who are left untreated. Not untreated with medicine. I'm not necessarily advocating for medicine, but do better than kids who just don't receive any treatment at all. With that said, you need to make sure that you're making an accurate diagnosis. If the kid by chance happens to have anxiety, and then you give a stimulant to a kid with anxiety, that's a problem. And of course, some kids will have ADHD and anxiety. So it just differs on a case-by-case basis. And you want to make sure that you are thinking critically about how you are seeking out treatment and assessment and diagnosis for yourself and for your kids, so on and so forth. So let's see. So let's move on to some of the things here. You can continue to chat as much as you like. So when we talk about really what is abnormal, how do we define it? We're talking about some sort of psychological dysfunction that is associated with distress or impairment in functioning that is not typical or culturally expected. Not typical for like a 7-year-old versus a 37-year-old, so on and so forth. And we call the scientific study of psychological disorders psychopathology. So usually when we're talking about abnormality, we talk about the 4 Ds. The 4 Ds are dangerousness, deviance, dysfunction, and distress. And this is why what we call the scientist practitioner approach is very, very powerful, and it's very, very important. So we assume that abnormal psychology and the study of psychological disorders is an applied endeavor, meaning that the reason we study psychopathology is so that hopefully we can understand it well enough to develop good treatments for it. And this is why the scientist practitioner approach is really important. We want our practitioners to act like scientists, and we want our scientists to think like practitioners. So scientists should be doing research that can help practitioners in the field provide better care for people who have the disorder. Practitioners need to think like scientists, and instead of just going with your gut, so to speak, or going off of what a parent might tell you or a teacher might tell you, you really think like a scientist and you gather data and you generate hypotheses. It's important to stay current with research in the field, which is challenging. And so if I can make a recommendation to you all, if you seek out treatment for a psychological disorder, try to find somebody who specializes in the treatment of that particular disorder. The reason being is that it can be very difficult to come up with a treatment plan that reflects the current research if you are trying to specialize in everything. Nobody can really be good at everything, but unfortunately a lot of people are trained to be generalists. And so, I refuse to see more cases than I actually see because I just can't keep up with everything. It's really difficult. So that's the scientist practitioner approach. Let's see. Clinical description, pretty obvious. One of the things that we think about when we're talking about describing the problem is how the onset occurred. Typically, not always, an acute onset is a good predictor of a quicker resolution to the problem. So when symptoms show up sort of out of the blue, suddenly, probably something has happened that if it can be corrected, the patient will get back to normal functioning. Not necessarily all the time, but generally speaking. An insidious onset, one that kind of creeps up on you over time and just develops slowly, it kind of percolates, this is not associated with better outcomes. We often will want to have what we call course descriptors. And course descriptors are important because certain disorders can be diagnosed or misdiagnosed based on how they appear. So when we talk about bipolar disorder, for example, it's important to look at the entire course of the disorder because typically when a patient comes into the office, they're complaining of depression. And unless the clinician asks a lot of questions about how the depression has occurred over time, you're probably going to miss when the patient had a bipolar manic episode at, say, age 20, now they're 40. And if that's the case, they get a diagnosis of bipolar disorder, not depression. So Julie asked a good question. Is PTSD a good exception to that acute onset idea? An exception to it? No. No. And the reason for that is because PTSD, we now understand, and it's reflected in the current diagnostic criteria. There are cases of PTSD which will come on relatively quickly. We don't, if it happens after the traumatic event and the symptoms show up, we don't diagnose PTSD for at least a month, thinking that it might just resolve on its own. And then there are certain, but then often it does turn into a case of PTSD. And then there are some cases of PTSD that sort of develop in an insidious manner, and these are usually in cases of chronic abuse as opposed to one traumatic episode. I hope that answers the question. Yeah, PTSD can often be misdiagnosed. It's often, well, again, it depends on the sophistication of the practitioner. Unfortunately, practitioners use language, and they're part of the culture just like you are, and we can sometimes fall prey to using language that the culture uses that it really isn't, that's sort of taken out of context. And so if I say somebody has been traumatized, we really have to be specific about what is a trauma. We'll save that for another day. People will sometimes call things traumatic when they're not really traumatic. It doesn't mean the situation wasn't painful, but getting it right is important because the treatments that we know work for disorders, they're always developed, not always, but probably 90% of the time when a treatment is developed, treatment X is developed to treat disorder X. We don't really have universal treatments that can be applied to almost any disorder. There's some examples of that, but not many, So, Anna's question, do you suggest therapy prior to diagnosing? Absolutely not. Absolutely not. Now, if if it's the case where somebody comes in for treatment and they need some help with their functioning, there's nothing wrong with starting treatment with a preliminary diagnosis, but it's up to the person making the diagnosis to treat it as a hypothesis. And then as you're treating, you're gathering more and more data. But all treatment starts with a good evaluation, hopefully one that's sufficient to make a diagnosis. Sometimes I'll hear people say things like, how could you make a diagnosis after meeting with me one time? The answer is, if you know what you're doing, it's really not that hard to make a diagnosis after meeting somebody the first time. The difference, however, is going to be, did the clinician do a very focused interview to get to a diagnosis, or was it more like a conversation? If it's more like a conversation, then absolutely not. And I don't recommend that type of evaluation. But survivor's guilt close to PTSD? No. Survivor's guilt is very different from PTSD. Most people with survivor's guilt will not have PTSD, but many people with PTSD will have survivor's guilt. So a lot of people with PTSD who were part of a group like first responders, fire, rescue, police, people in combat, they will often report guilt over having survived, particularly in the situation where you consider it an honorable thing to die, in the service of your country or service of, putting out fires or whatever it is. Hopefully that clears some things up. Well, you guys ask good questions and you're very chatty. I love that. I love that. So it's 9:06. I'm going to keep going, and if you need to jump off, you can jump off. That's pretty cool. Be my guest. I'll talk more about PTSD in probably the next call when I talk about anxiety. I can certainly talk a whole lot more than that. There's the area of post-traumatic stress disorder is so complicated that in the latest version of the diagnostic manual, when I say the diagnostic manual, this is what's described in your book as the Diagnostic and Statistical Manual of Mental Disorders. It's the 5th edition came out in 2013. Trauma proved to be so complicated, we pulled it out of the category of anxiety disorders, and it now has its own separate category. It is its own category of psychological disorders because trauma can be very, very complex and take a whole lot of different forms. So we'll talk more about that. Goodness, what else do I want to try to hit tonight? A couple of definitional things. Etiology, it's important to study. We want to know what contributes to the development of psychopathology. Notice the language that I use there when I talk about etiology. It does not say what causes psychopathology. It's what contributes to the development of the psychopathology. Okay? You're not going to find a cause for a psychological disorder. This is the concept of multifinality. Okay? Multifinality is the principle that says there's lots of pathways to any specific outcome. So always keep in mind that every behavior is multi-determined. Every case of psychopathology is determined by multiple things. There's not a gene for everything. There's not a specific cause for everything. Yeah, you have to have an exposure to a traumatic event to get PTSD. However, there might be lots of people exposed to the event who don't get PTSD. It's really interesting to find those people and to figure out what's different about those people. For example, people who are sexually assaulted but don't develop PTSD, they're abnormal. And we want to know about those people because they might have some strengths or some resiliencies that can be really useful in helping other people. And it really informs treatment development. How can we alleviate psychological suffering? So here's the other piece that you probably don't want to hear, and that is that we don't have a documented cure for any psychological disorder. We have treatments that help. We have therapies, psychological therapies that help, behavior therapy that helps, cognitive therapy that helps, medication therapy that helps, family therapy that helps. And we can get a person to the point where they no longer meet diagnostic criteria, perhaps. In other words, They may perhaps have post-traumatic stress disorder, but because of the treatment they receive, they can function very, very well, but they're not cured. They're not cured. The other thing that I'll mention about treatment is I would ask you to please resist the very tempting idea that for any given disorder, if we know that medicine helps and we know that therapy helps, that combining the two is definitely the way to go. That is not the case at all. There are cases where therapy plus medication works better than medication alone. There aren't many examples of therapy plus medication working better than therapy alone. For some cases there are, right? For ADHD, stimulant therapy works better than psychotherapy, works better than behavior therapy, okay? Again, according to the research, your results may vary. If you have bipolar disorder, a mood stabilizing drug like lithium will beat therapy and the combination of lithium and therapy every single time. So just think critically. Just because two things work doesn't mean that putting them together will work. Think of it like cooking, right? You might like lasagna and you might like ice cream, but you probably wouldn't mix the two together and expect to have a good outcome. Unless you're weird and, whatever. So treatment outcome research, and I'm probably going to leave it off here. Unless there's other questions. It's important to study psychopathology and study treatments that actually work so that we can communicate to the people in the field how to best help people with psychological disorders. Unfortunately, there is still a lot of practitioners who hold on to old, antiquated ways of thinking about things. Old Freudian models. Not good. Not good at all. The idea that you have to somehow uncover the problem and get to the root cause as a way to fix the problem. It's just not the case. What works to treat any disorder? I'll tell you exactly what works. It's exactly what treatment research says works. Now, that doesn't mean that you shouldn't try some novel things, okay? So, for example, there was some chat going on about changing diet to help with ADHD. Yeah. If changing one's diet helps with symptoms of ADHD in your kid, by all means, right? As long as it's a healthy diet change, I guess, right? However, I will tell you that the research on using that as a treatment modality hasn't really panned out. There's not a whole lot of good data that suggests changing your kid's diet is going to help with ADHD. Should you try it? Sure, why not? Put them on a healthier diet, see what happens. I don't know. So there's an awful lot of stuff that we just don't know about. My recommendation to you is if you seek treatment for a psychological disorder and somebody presents a treatment option to you, the first question out of your mouth ought to be, what's the likelihood that's going to work? What's the evidence that this actually works for my problem? That's really the key. And if you can't get to a diagnosis, you might just treat symptoms. That's okay. And of course, if you study the course of the disorder, and it seems like it's a rapid onset and it might go away quickly. For example, anxiety. I specialize in the treatment of anxiety. I don't want my anxiety disorder patients taking something like Xanax, a very powerful, highly addictive anti-anxiety agent. Okay? I don't want them on it. They're going to become dependent upon it, literally, physiologically dependent upon it. And more importantly, it's going to get in the way of the treatment that I want to do. That's a big deal. At the same time, if I have a patient in the hospital who is falling apart because her husband was in a car accident and he needs surgery and he's teetering on the edge of life and death and she can't stop crying and she can't sleep because she's sobbing constantly, for goodness sake, give the woman some Xanax. Okay? Just give her some symptom relief. she probably doesn't have an anxiety disorder. She has anxiety symptoms, but she doesn't have an anxiety disorder. She has a very strong reaction that is culturally expected, and she needs some relief to help her cope. Go ahead and give it to her. Okay, so it's 9:15. I've been talking for about 50 minutes now. Probably a good time to stop. Are there any additional questions or comments or things that you want me to touch on from anything in particularly chapter 1 and 2? I'm not seeing a whole lot of chat going on. Are you guys still there? Still awake? Yes, yay. When will the slides be posted to Blackboard? I'll do it right after this call. Sort of my summary of the most important points from chapters 1, 2, and 3. Your book argues for a multidimensional model, looking at a system of influences. Pay very close attention to that. That's important. It's important. One-dimensional model is, people get very, very stuck on their own way of thinking. A multidimensional model is a little bit more difficult because it requires you to think in a comprehensive way, and it often involves involving other treatment providers, so it can be a little bit difficult. Chrissy wants to know, is there any way we can do a class cafe type thing? Maybe. What is that? Class cafe? You want to meet for coffee? I suppose. If you're buying, I don't know. Do you mean just a place in general where you can chat, Chrissy? Kind of like you're doing tonight? I thought that's what you meant. It's late. I was being a smart aleck. Kind of a discussion board, meet and greet. Sure, yeah, I can do that. Would that be good? We'll make it voluntary. You don't have to do it, but okay, I can do that. Maybe I'll set up that tonight when we're done, and you can share what you really want to get out of the class, and maybe you can, just a place to chat back and forth. Like talking about the material. Good, good. Excellent. And if there's stuff that comes up in your own discussion, I probably won't be in there monitoring that board really closely. I can if you want me to, but if there's stuff that you specifically want me to talk about or, again, prepare a mini lecture on, you just let me know. Sound good? We'll be talking about the autism spectrum at all. That is very late in the course. It's like at the end of course. But if you remind me, I can make a note to talk about that a little bit more in one of our later calls. I'm happy to do it. I'm not an expert on that area, but I can certainly give you some pointers. A mini lecture on PTSD would be wonderful. Okay, I can do that. A mini lecture on that too. What was that first? Oh, and a mini one on autism too. God, you guys are going to make me work. No, I'm kidding. Yes, I can do that. I can do that. I'll pull some things together. Whatever you need, I want to make sure that I want to make sure this is a good class for you and you get kind of what you need, right? You get free access to a clinical psychologist. You want to get your money's worth, right? All right. Good. All right, well, why don't we break then? Thank you all for participating. Thank you all for chatting. So I'll set some stuff up on Blackboard. This recording will be done. It usually takes about like 24 hours for it to get done, 48 hours for it to get done. But when it is, I'll post it online. Get some other perspective. Good. Okay. Excellent. All right, folks. Then let's call it a night. It is late, and we should all get ready for bed because I want you to get good sleep because that's really, really important. I'll probably talk a lot about that. And all right, so look for more stuff coming up soon, and we'll talk. Have a great night.